Executive Director of the Canadian Public Health Association, and I am pleased to welcome you to today's CPHA CJPH Journal Club. I want to start by acknowledging that CPHA's offices are located on the ancestral and unceded territory of the Algonquin and Anishinaabe peoples, and CPHA is committed to meaningful and ongoing truth and reconciliation with all of Canada's Indigenous peoples. Just on a technical note, for attendees that are joining using the link that was just sent out, my apologies. You're all showing up in the participants list as Ian Culbert. I've never seen so many Ian Culberts in one room at one time. My apologies for that, but we had to do a end run around technology, and so there's always going to be something tricky when that happens. So when it does come time for the Q&A section, if you want to be able to differentiate your Ian Culbert from the other Ian Culberts, you may want to put your last name at the start of your question so that our MC today, Monica Mode, CPHA Student Director, can identify the questioner. So with no further ado, I will turn it over to you, Monica.
Thank you, Ian, and thank you everyone for being here today. It's my pleasure to welcome to our second meeting of the Journal Club series, held in partnership with the Canadian Journal of Public Health. So at CPHA, our area of work is to advocate for public health, speaking up for people and populations at all levels of government. We champion health equity, social justice, and evidence-informed decision-making, and we're a catalyst for change that improves health and well-being for all. Our vision is a healthy, just world, and our mission is to enhance the health of people in Canada and to contribute to a healthier and more equitable world. You can follow us here on Twitter. And the Canadian Journal of Public Health is an independent journal that publishes peer-reviewed research, peer-reviewed original research and scholarly articles submitted in either English or French that are relevant to population and public health. This journal aims to advance public health research and practice in Canada and around the world, contributing to the improvement in health of populations and the reduction of health inequalities. And you can find their Twitter linked here on this page. And so for those of you who are new here, for the past 4 years, we have been holding a webinar series to engage our members. Initially, this series was primarily intended to tend for students, trainees, and early career professionals within the goal of promoting public health careers. You can find the recordings from the past sessions on our YouTube channel. And this year, we are holding a series in partnership with the peer-reviewed journal that we publish, the Canadian Journal of Public Health. Each month, a graduate student will critically appraise a different journal article and will engage the paper's author in discussion. A committee of devoted volunteers has identified the first 4 articles, and registration for webinars opens up a month prior to them taking place. So our hope is that this Journal Club series will provide a supportive learning environment for our participants to keep abreast of the current public health literature, develop skills and competencies in critical appraisal, and to expose participants to a range of methodological and analytical approaches used in public health. We hope that you find these sessions to be invaluable throughout the year, and we hope that you will follow along on the conversation during the webinar and after the webinar using the hashtag CJPH_J Club. And I'm looking forward to another exciting webinar presentation and a really thoughtful discussion to follow. But just before we begin, just a few housekeeping things. So all participants are muted, but we hope to engage you all through the webinar through polls and other features. So at the bottom of your screen, you'll find a toolbar. So if you have any general comments, you can post them in the chat box below, and this will be visible to all participants. And we encourage you also to chat on Twitter as well. And so if you have any questions for the presenters, please use the Q&A feature to ask the presenters a question, and your questions will be answered in sequence. So just a reminder that this webinar is being recorded, and the recording will be available to all our members and registered participants shortly following today's session. So the slides and recordings will be available more broadly in about 3 months. And now for my favorite part is I get to learn more about who is attending our session today. So please take a minute to answer some of these polls. So we have several PhD students and early career professionals joining the meeting. Thank you, and 2 master's students. And for region, several people from Ontario, but also from BC. And what's your primary focus, area of focus or interest? Oh, perfect. It's always nice to see we have a good mix, but lots of research. So maybe I anticipate lots of methods questions today. And for the final question, what's your level of comfort in using sex and gender-based analysis in your research? Oh, so it seems like I have a mixed bag. It's going to be a very exciting conversation today. So without further ado, I want to introduce today's presenters. So Amanda Doggett is a PhD candidate at the University of Waterloo in the School of Public Health and Health Systems. Amanda currently works with data from the COMPASS study, a large longitudinal cohort study of youth across Canada. Her research has mainly focused on substance use behaviors among youth, and she has a particular interest in quantitative methods. Currently, her dissertation work focuses on the impact of missing data and youth BMI research. And our author, Anaïs Lacasse, who is associate professor in the Department of Health Sciences at the University of Quebec. She is trained in pharmacoepidemiology at the Faculty of Pharmacy in Montreal University. She's an associate professor in the Department of Health Sciences and is a junior 2 scholar of the Fonds Research du Québec, Fonte, in partnership with the Quebec SPORE Support Unit. And her research program aims to better understand the treatment of chronic pain in real-world clinical contexts. Specifically, her research program explores 3 complementary research axes: the healthcare trajectories of people living with chronic pain, the use of drugs for treatment of chronic pain, and the linkage and validation of databases and measurement skills for research in this field. In addition to her research, she's also actively involved in several FRQS research networks, especially as co-director of Quebec Pain Research Networks and a member of the steering committee of the Quebec Network on Drug Research. And so I'm going to hand this over to Amanda to begin her presentation.
Okay, I'm just going to share my screen here. Okay, Monica, can you just confirm that you can see my screen? Perfect, yes. Thank you. Thank you. Okay, so welcome everybody to the webinar today, where I'll be talking with Anaïs about her paper where she and her colleagues created a gender index from a data set where gender information wasn't available. So I'll spend about 15 minutes going over the background methods and the results of the discussion of the paper. And then we'll leave the rest of the time dedicated to like a Q&A discussion. If you have questions that come up during the presentation, don't feel like you have to wait till the discussion time. Just feel free to throw them in the chat so that they're there when we have the discussion. Okay, so to start off with some background information, I think to start off any kind of sex and gender-based analysis, it's important to start by talking about the differences between sex and gender. So sex is a biological measure consisting of female, male, and intersex, and it's more commonly collected in research in comparison to gender. Actually, usually it's collected as a binary measure, just male and female are typically included. Whereas gender is a social construct that exists on a continuum. And I really like CIHR's resources on sex, gender in health research. And their definition of gender is socially constructed roles, behaviors, expressions, and identities of girls, women, boys, men, and gender diverse people, which I think sums it up nicely, because you can see that while they're separate concepts, they're also very interrelated, sex and gender. But you can kind of tell by the definition and the fact that it's not just binary or categories that it's more difficult to capture in research. And historically, it hasn't really been included. for the people who are researchers in the audience, which I think from the poll we had a few, if you're conducting your own research, in the beginning of this paper, Anaïs actually cites a lot of validated self-report indices for gender. So if you want to incorporate that from the start, which is obviously a good option, you can take a look at those. But what we're talking about today is kind of deriving that information when gender wasn't collected. So first of all, I think it's also important to talk about why do that, why be measuring gender in research as opposed to sex. And broadly speaking, gender influences a lot of different things. It influences the way that we perceive ourselves and others, and it influences how we interact with other people, and of course, the distribution of power and resources in society. So you can see why gender would kind of influence every facet of health, whether it's health outcomes or health behaviors, and also extend to other domains as well. So it's important that we kind of look beyond sex and look at gender in research. So again, though, how do we do that if it wasn't really collected from the start? So we're going to kind of talk a lot today about gender-related variables. So we're using gender-related variables to try and create some sort of index or some sort of measure of gender. So it's worth mentioning, what is a gender-related variable? So some examples of gender-related variables are things like time spent on childcare, someone's occupation or employment, the number of hours they work, their stress levels, and there's many more examples as well, and we'll see a few more later. But from a method standpoint, it's pretty useful to be able to transform all of these variables into a single composite score, because there's only so many variables that you can include in a certain analysis that attempt to proxy something else like gender before it's just too messy and you have too many variables and you start losing statistical power. So it's more efficient if we can kind of develop some sort of composite score. And it also has direct interpretive value. If you have one measure with kind of one, beta coefficient or something associated with it, you can actually interpret that. So that's what gender-related variables are and why we would want to create a composite score. So how do you do that? How do you create some sort of composite score for gender? So this has been done a few times before. So Smith and Kuhorn took the approach of, they had some gender-related variables. So like I mentioned on this slide, time spent on childcare, occupation, they had variables like that. And they created like a single summed score. So essentially they took people's responses to those type of variables and they decided, okay, if they responded this or this, they were a 0. If they responded this, they were a 2. And then they took all those and they created a composite score from 0 to 10, where 10 represented more feminine and 0 represented more masculine on a continuum. The problem with this kind of approach is that the response groupings, like the 0 and the 2 and everything, are researcher decided. So essentially it is a subjective representation of masculinity and femininity. And while that's probably based on their examination of the literature, it is still a subjective measure. So another approach is to do what Pelletier did, which is instead put all those gender-related variables into a logistic regression model where the outcome is sex. And remember, I mentioned sex is usually collected in research, so you usually would have access to that more. So if you have a bunch of predictors that are predicting your outcome being sex, then you have an ability to create a composite score, which is what Anaïs and her colleagues did. And there's less subjectivity around this in terms of the processing of variables, because you're kind of letting the model do that for you. So speaking of this approach, let's move on to talking a little bit about the methods. So I'll mention briefly the data sources that were used here. So the data set that was used was the Torsade cohort. I hope I'm pronouncing that right. I think it's Torsade, which was actually a linkage between two other data sets, the Canadian Community Health Survey, which I think most people are familiar with, and then the RAMQ database, which is like administrative databases in Quebec, which I actually wasn't familiar with myself. So it was cool to learn about that. So it was linked, those two data sets, which resulted in about just under 70,000 individuals living in Quebec were in that Torsade cohort. And in terms of how Anaïs and her colleagues described in this paper how they did their gender-related variable selection among all the gender-related variables that were available to them in that data set. They looked at existing literature, including the multifaceted gender and health model, gender constructs, which you've probably heard of before, like gender roles, gender identity, gender relations, and institutionalized gender. And then they also reviewed other studies that looked at composite gender indices. And they ended up with a host of variables, which this is an excerpt from table 1 on the right-hand side. So they included things like household income, the size of the household, if they worked in the past week or in the past 12 months, those things like that. And what they found was that employment variables were particularly important. So actually this particular index in this study only includes people 18 to 50 who were employed within the last 12 months. And that's just because they found from the existing literature and from the modeling that employment was a particularly important gender-related variable that needed to be included. And you can see there's a variety of employment-related variables that they didn't include. So this slide is actually from Anaïs, so she sent this to me. Thank you for that. And I found this helpful to kind of understand the classifications of the different things that were included in the index. So she actually went and she categorized this based on the different gender constructs. So which pertain more to gender roles, which pertain more to gender identity, gender relations, and institutionalized gender. And you can see kind of from this slide that it's not, there are overlaps and it's not always kind of straight one-to-one. So yeah, definitely a complex analysis for sure. In terms of the process that they used, they created the index first, which I'll talk about in a second. And they looked at face validity and construct validity. And face validity is like, to what degree are the variables associated with the index, which really means like, are the variables that they chose to put in the index relevant? And construct validity is looking at whether or not that index is consistent with what we would expect. Based on what we know about gender, does the index act the way we would expect it to act? So in terms of how the index was actually created, Anaïs and her colleagues used propensity scores, which I'm not sure if people are generally familiar with this or not, so I'll talk about it a little bit. But a propensity score is actually fairly simple. It's just a score created based on individual characteristics that are relevant to a study, like age, height, any sort of demographics, really anything. And propensity scores, although that's not the way they were used in this study, they're often used to attempt to mimic the randomization component that you see in experimental designs, but in observational studies, because we can't randomize participants in observational studies. So sometimes propensity scores are used to kind of balance the demographic characteristics between participants at baseline. So you give people a score and you match them between groups, so you have a little bit more balanced demographics between those groups. But in this study, that wasn't the approach. They just created a propensity score for each participant. And in this case, the score represented the conditional probability of being female, of having reported being female sex on the survey. And the way that they did that was just a logistic regression where the outcome was 0 or 1, 1 being female, and all those gender-related variables were the predictors in that model. And then because it's a probability, the score ranges from 0 to 100. You can export that to a new variable in the data set. And that is your index. And the higher the score, the more feminine characteristics. And the lower the score, the more masculine characteristics. Hopefully that made sense. So let's talk a little bit about the validity stuff that I mentioned earlier. So now that after they created the index, the next thing to do was to look at the face validity and construct validity. So when they looked at the face validity, they found that almost all the variables that they included in the index were relevant to the index value. They were significantly related to the index value. So that kind of confirmed that they did, in fact, include gender-related variables that were relevant to gender. And something I want to point out too is that the associations that you see in the table are as might be expected based on what we know about gender. So I just pointed out a few on this slide here. This is table 4 from the paper. But for example, you can see, remembering that higher scores are more feminine characteristics. So when you see a negative beta estimate, that would mean that there was more masculine characteristics. So you can see here that more feminine characteristics associated with making less money, which makes sense based on what we know about the differences in income between men and women. But women were more likely to rely on child support as the main source of income, which again corresponds with what we know based on existing research. And same thing with the occupational variables. Like, we know that women are more likely to work in healthcare and social assistance sector, but they're less likely to work in construction. And that's reflected in this kind of face validity analysis as well, with the direction of the beta estimates. So that's also something I just kind of wanted to point out. The next thing that they looked at was construct validity. So first of all, I want to point out the figure 1 from this paper, because I think when you think about the index, it's kind of easy to picture a graph where there's like 2 mounds, but that's, remember, if gender exists on a continuum, for the index to be valid, you would expect to see that the scores are partially independent, but they're still related. So you would expect this overlap, which is exactly what you see in figure 1, where you still have low scores that correspond to women, and you still have high scores that correspond to men, but just not as many. And the other way that they looked at construct validity was they looked at variables that weren't included, like they purposely did not include them in the index because they wanted to use them to examine the construct validity of the index. And what that means is that they had variables that they knew were related to gender in a certain way, but they left them out of the index. And at the end, when the index was created, they just checked whether or not the index was related to those variables in the way that they would expect them to be. So you would expect, based on existing research, that a higher gender index score would be related to things like avoiding certain foods because of body weight concerns, because we know that's associated with more feminine characteristics, and that is what they found. And these things were also consistent with the other construct validity variables that they analyzed as well. So I think the last thing I'll comment on is in terms of what is the usefulness of an index like this. Well, I kind of alluded to this in the beginning, but there's a lot of value statistically and interpretively, I don't know if that's a word, value for interpretation, of having a composite measure that's multidimensional when you're modeling health outcomes, because rather than including a host of 5, 10, 15 variables that are attempting to proxy gender, if you have one measure, you're maintaining statistical power, because every time you kind of include more variables, you lose a little bit of power. And it's also more feasible, right? Including less variables is always going to be more feasible. And it's also more feasible to test interaction terms, which we're very interested in health research, particularly with sex and gender. We typically look at interaction terms with those variables. So it's very useful for that as well. And you could also do things like you could use the propensity score value and match them, like I was mentioning before. If you were looking at, kind of an exposure and unexposed group for something, you could do that. You could also do subgroup analysis where you choose some particular cutoff value of the gender index and stratify that way. And I'm sure there's a lot of other useful ways that you could also use this index that I haven't mentioned yet. So if you can think of something that I haven't mentioned, please feel free to throw that in the chat. But I think I'll leave the summary of the article there, and we'll move on to the discussion stuff. I've put the Twitter information on this slide too, if you want to chat with us on Twitter or message me on Twitter or something like that. But yeah, looking forward to the discussion. So Monica, I can't actually see the chat at the moment. So do we have any questions at the moment? I have a few, so if there's none yet, no worries.
No questions yet, so feel free to go ahead. I'll wait to see as they come in.
Okay. Something I wanted to chat with Anaïs about is we had a previous conversation before this webinar, and I think something that's worth bringing up, especially because in the poll, I think there were master's and PhD students, so kind of earlier researchers in particular, was you mentioned to me that you got a little bit of pushback on the index because it's an imperfect representation of gender, right? It's not this kind of like perfect measure that can be applied in any scenario. And we had a conversation about it's not perfect, but it's kind of the less worse approach to including gender. So I was wondering if you could speak to that a little bit and your experience with talking about this index to other researchers and their response to it.
So thank you, Amanda. First, very good appraisal of the paper. I liked very much your presentation. It's interesting to be able to discuss the paper today. Yes, okay, so the best way would be to do a prospective study and include the self-reported gender measure construct and all these things. But in the face of existing database, so we have to work with what we have. And there was like 2 or 3 options. So you said it used the variable that could be related to gender, but there's limitation in terms of statistical efficiency. We could take variable and give points to participants, but it would be very subjective of what's feminine, what's masculine. So we opted for the Pelletier and colleagues approach. And it was a little bit criticized because we'd use sex as the dependent variable for the creation of the score. But I think the figure you presented is very insightful at this level in terms of the score. When we look at it, it's related to sex, but it measures also something else. If it was measuring the same thing as the sex, the graph would not be like this, like every woman would be feminine and every man would be masculine. So as you said, I think it's the least worst approach. And remembering that if we want to consider gender when using existing data, it's an option, but you know, in research methodology, nothing's perfect. But I would like to hear the opinion of the participants at this level. So I think many reported in the poll that they had experience with measuring gender. So.
Yeah, absolutely. I'd be interested to hear if their experience with it is like it had been included from the research, like from the research outset. So there was kind of a validated, or maybe even if it wasn't validated, like measure of gender in the research or not. I think it's important to hear these perspectives because sometimes, at least when I was, starting as a graduate student, I was maybe incorrectly looking for the perfect model when I was doing analysis. And as you get further and further, you realize that like that doesn't exist. There is no perfect model. There is no true model really, right? So you kind of get comfortable with what is the least bad or least worst way I can do this. And I think that now we're moving more towards the least bad way is including gender rather than just being like, all I have is sex, let's just include that. Because we're recognizing that gender is related, but represents a different concept and something that isn't necessarily captured within binary measure. So yeah, I think that's important for early researchers, especially to kind of wrap their head around, is like the modeling process is never going to be, this is the perfect way to do it. But it's like, what is the least bad way to do it, and how can I contribute to that?
And in the context of the TORSAD cohort, our goal is to study healthcare trajectories. So we want to know if sex and gender have an impact on that. And even if the measure is not perfect, if we found associations, interaction, then it could be a further study in a prospective study. So it's like more of a way to adjust for gender, and also maybe screen if gender has a role in the healthcare trajectory we are interested in.
Speaking of that, do you know any teams that are currently working or planning on using this index with CCHS or with the TORSAD cohort now that it's been created?
Yes, since it has been created, it's available to all researchers who want to work with the Torsade cohort. For now, we are different teams who work on different chronic disease, chronic pain, MPOC. It's a COPD in English, sorry. Obesity, depression. So all of these chronic conditions, there's different teams that are working with the Torsade cohort, so they can all use the index. It's available for everybody. And of course, the algorithm cannot be applied to another different database, but it can be a methodological example. And if someone is working with CCHS elsewhere in Canada, we could share our algorithm. It's not so very difficult to do the logistic regression, and we add in SAS a little output for propensity score. It's added in the database. So the more complex thing was to decide all the choices before running the logistic model. So this was long, but running the model is not hard if you have access to such variable in other province. It could be achieved.
Do you know if the Torsade data is available for any researcher to use, or is it something that you kind of go through an application process to get access to?
It's an application process, so it's an infrastructure of the spore support unit in Quebec. So there's one in each provinces of Canada. So it was put in place by the spore unit. So after researchers interested to using data can contact the unit, there's a website, and ask for many things, help with partnering with patient, help with methodological aspect, or access to data. So the SPORE platform is there for helping researchers. The proposal can be submitted to use the cohort. There's equivalent in many Canadian provinces already linked data between CCHS and administrative database. So I don't know if researchers in other provinces have an advantage of coming to Torsade instead of their jurisdiction data. So it could be interesting. Every database at the provincial level have differences. So maybe it could be interesting for a researcher to step outside his yard and come to Quebec data.
I have one question from the audience. Someone asked, while creating the gender score, did you encounter any interaction between any of the variables involved in creating the gender score?
We didn't test interactions, but we tested for multi-collinearity. So every variable included, there was no multi-collinearity problem. So, but we didn't test the multiplicative interactions in the model.
Speaking of, you mentioned kind of like, oh, if researchers were staying in their own province or going to Quebec data, I actually have I have a question related to that, and it might be kind of a weird question, but I was just thinking about like the generalizability of using this index. And so like, because you used a Quebec specific data set, I suppose the results wouldn't necessarily be generalizable outside of Quebec. And as someone who's like never lived in Quebec, unfortunately, I don't really have any lived experiences to draw from, but I'm wondering if can you imagine that there might be ways in which like gender roles or gender identity or anything like that would somehow be different in a Quebec cohort than it would be in other cohorts, in other provinces or anything? I don't really know if that's a fair question, but I was just trying to think of, would this index look the same if we were to recreate it in another province?
It's a very good question. I think there's cultural differences that can be there between the provinces. There's many studies in many health fields that found province differences. But if we would be to reapply the algorithm to, for example, Ontario data, people would get different scores that they have we would get a different distribution of scores that the one we had in Quebec, maybe not. But if yes, the distribution would be different. The question is, like, when we are in the scale validity field, a scale should always be retested when used in a different population. So we didn't do subgroup analysis, for example, verify if patients suffering from diabetes have a different validity profile than other ones. If enough tests would be conducted to see this, and the validity of the scale would be stable across groups, I think it could be okay to reapply it in other provinces. But it's a good question. We would have to think about that.
Can I ask a follow-up question? So oftentimes when we talk about developing measures, especially when we think about generalizability, so especially when we talk about developing measures, there's always a talk about finding a balance between the base validity and the construct validity. So I'm curious if you could tell us a little bit more about, about base validity and construct validity, and how you went about assessing each, and how to kind of find that balance between the two within your index.
In the case of face validity, it was really if variables were useful for a gender index. So we wanted to increase this by using the literature. So we went to review a known model, the Becker model, Johnson gender constructs, and also other studies that developed composite scores. We work with an expert in the field of gender, and we reviewed every variable that were available in the CCHS cycles we worked with. So we hope that it led to a good pool of variables. After we excluded some because of technical aspect, if there was too many missing data, or the variable was not measured in every CCHS cycle we had. But after we did some verification to see which variable in our index are the most important ones. So Amanda said that it would work variables. Mm-hmm. So the face validity, it's not really some statistics. It's much, are we considering the good things? Are we making good choices? And afterwards, statistics were used to verify construct validity, but it's not a perfect validity study. So we didn't measure every psychometric properties of the index. We measured what was possible with the data we had. So we cannot see the paper as a definitive proof of the validity of our index, but our preliminary analysis, they point towards that. It seems good.
Speaking of that, I actually have a follow-up question to what you just mentioned. When you were reviewing the literature for gender-related variables, were there any variables that you came across as the literature said these are particularly important, but you didn't have access to in the Torsaid data, just either because the questions weren't asked or for whatever other reason?
Everything is asked almost in this situation. It's
it's a large data set.
So many, it was not the creation, the statistics that were hard. It was the beginning. So there was so many variables to review. Next group of person reviewed them. We made a consensus. At the beginning, we were very inclusive. So we didn't exclude on the basis that, for example, 2 members of the expert committee said no and 1 yes. If one people thought that it was relevant, we considered it. So I think that the things we measure were variables that were not measured in every cycle. So we saw that, for example, eating some things to not to lose weight is a feminine characteristics. In the ideal situation, we would have considered it, but we could not because it was not measured in every cycle. So many healthcare use or medication use variable can be gender related. We didn't consider them because they are like our main outcomes using the Torsade cohort. So we didn't want it to be in the gender index. So everything that was like a health outcome was not necessarily included, more like social determinants of health we looked at.
So it more consisted of like the demographic variables so that there was no overlap if somebody did want to use the index to look at medication or health, like any of the health outcomes or something like that. Yeah, okay.
So for example, hours of work in a week can be a proxy for gender-related constructs, but using opioids is more an outcome. So we had this idea when looking at a potential variable to be included in the index.
I can keep going with questions, Monica. I just want to make sure I'm checking in though. Do we have any questions that were put forth to you specifically in the chat?
Not yet from the audience, but we're welcome. I just want to remind everyone we're welcome any and all questions, so feel free to ask.
Okay. I have actually one more question that in terms like related to what we were just talking about the index. I was looking at some of the variables included, and I think unsurprisingly, a lot of the measures could proxy like disadvantage in some way, because I think there's like food insecurity in there, and there's income and employment and stress at work and stuff like that. And you notice a lot of, if you look at that table that I pointed out, you notice a lot of those measures of disadvantage are associated with more feminine characteristics, which to some degree isn't particularly surprising. But I'm wondering then, is this something that came up when you were looking at the gender literature, like the kind of relationship between feminine characteristics and disadvantage? And then is the index representing femininity, or is to some degree it's also representing disadvantage in a certain way?
Yes, I think one of the main goals to consider sex and gender is to understand inequalities, which are, I think, which are known to be present in women. For example, just in the current pandemic, women were again disadvantaged. For example, schools were closed. Often women have a greater part in taking care of the child, had finally maybe more stress at work because they cannot do their hours. Men too, but men who have important roles, for example, in family caregiving, are men biologically, but have different gender implication in their families, for example. So I think the index can capture this. And when you presented, when reviewers went through the paper, they asked, so what is your index measuring? So I don't think we can say a specific construct. I think it's a multi-dimensional gender construct, a gender index that is not covering only one gender construct. When, for example, we are looking at Johnson gender construct.
Yeah, like you can't kind of box it into this is just gender roles or just gender identity. It kind of spans across all of those. Yeah, it's definitely a bit to wrap your head around for sure when you think about the different ways that the index could be used and interpreted. Is there a specific like lens that you would hope that researchers take when they're using the index? I know you mentioned that you expect it obviously to be used with health outcomes and medication, but is there any, like, let's say someone in the audience was to kind of go forward and use this index, is there any kind of things that you would want them to keep in mind when they're actually presenting their results?
I think it could be seen as a screening tool to verify if there's inequalities.
Mm-hmm.
When there's a poor healthcare trajectory or health trajectory, identify where we can act. Sometimes there's sometimes risk factors for something can be modified, sometimes not. Sometimes approach from, for example, healthcare professionals could be tailored to the patient they have in front of them. Sometimes we do not know there's inequalities, so we have to be just aware that they are there. For example, for healthcare professionals. So maybe it could be used as a screening tool to detect some places that we didn't knew that we should consider gender in that field or in that situation.
And I think it can be contrasted too if someone was to use the, and maybe this would be a different paper completely if they were doing it, but if they were to use the gender index and then also do the analysis just using sex and see, there would be very illustrative differences, I would think, even just the fact that one would be a continuous measure and one would be a binary measure, but it kind of illustrates that sex isn't really capturing maybe all of what we're trying to look at, especially if we're going to go a little bit deeper and think about disadvantage and stuff like that.
Because the access to TORSAD court has to be in the physically in some bureau in the province, but because of the pandemic, had like delays. So I'm waiting maybe tomorrow to have the access for telework to the database. So our next step is really to model health care utilization trajectory. We will use a latent class approaches. And after this variable will be used as the dependent variable, and we will check for sex, gender interaction, so as potential social determinants of healthcare utilization among chronic pain patients. So this is our next step. I hope we will have a result until Christmas.
Yeah, so you're just waiting on access to the data set then?
Sorry, yes.
Yeah, okay. It's unfortunate when that's a roadblock, but I think we've all been there.
The pandemic is problematic for data access too.
Yeah.
So question from the audience. So if you're only interested in one specific gender-related concept, could you modify the index accordingly and adjust for only those relevant variables?
The current index is not only considering gender role related variables. If someone would be interested in gender roles, maybe could review all the literature specific to this construct and reapply a method that use only variable that could be related to this construct. So if they are working with existing database, it could be an option, but it's all intertwined, these gender construct. We saw with the Amanda presentation that many variables are associated with, according to the literature, associated with more than one construct. So I'm not sure it's possible to isolate a construct with such a method. Maybe with a prospective study, with a self-reported validated questionnaire, maybe it could be possible, but in our context, maybe it could be difficult to say that we are only measuring this construct, for example, the gender roles.
It sounds like statistically it's probably feasible because they would just kind of modify the same approach that you use with the regression, but the literature is probably a little bit the muddy part there, where it's like, how do you figure out what is a gender role versus which only pertains to gender identity and stuff like that. I think I can't even imagine the difficulty that you would have to sift through the literature to do that.
And maybe it's possible, but because I'm not a gender expert, I'm a chronic pain researcher who wants to try to include sex and gender in her research. So it's quite new to me. So maybe I don't know the whole literature on gender. Maybe Johnson constructs are criticized. Maybe there's other way to conceptualize gender. So I'm aware that maybe there's an answer that I don't have.
I'm curious to know, so thinking from a statistical perspective, I know you mentioned in your introduction to your paper that like some of the previous authors used something called the principal component analysis. And so for those in the audience who aren't aware, so PCA is a statistical technique that's closely affiliated with factor analysis, and it lets you kind of examine how variables, I would say, like hang together. And so you can see, and that will allow you to kind of reduce the size of your data set. So in studies like this, where you have so many variables, like 43 of them, you might be able to see how those variables are kind of closely related. And so I'm curious to know, I think something like a principal component analysis would be particularly useful in this case in terms of kind of teasing out those particular things around gender roles or gender identity for potential future application.
If the objective was to see the relations, I think it would be a good idea. Pelletier used it. In our case, we didn't use PCA because we had so much participants in terms of sample size that we didn't had a need to reduce the number of variables in our multivariate model. So we wanted to use them in case they are relevant. Finally, many, almost, I think on the whole set of variables, there was one that had poor association with the index itself. So they were all relevant. If researcher had, for example, 1,000 participants instead of 60,000, maybe they had to do choices, and a method to give up some variable could be PCA.
Mm-hmm. Yeah, it's hard too, because I imagine with propensity scores, you need a lot of variables to be able to make that score. So it's like that trade-off too of like, how much would you reduce your data set to be able to get an accurate estimate score? So there is a trade-off. And like we talked about earlier, like the least worst method, like you have to kind of make trade-offs there.
Like we wanted in our study to consider every variable. So we didn't, we had the chance to have a great sample size. So.
Mm-hmm. And I think when you're developing something like this, where it's intended to be an index that represents gender as much as it possibly can, there's almost no harm in being kind of liberal with the things that you are including, versus, let's say, if you were building a model that you were hoping to like interpret to inform some sort of policy, maybe you want to be a little bit more strict with what variables you're including, because if they don't have interpretive value, then, or if they're not particularly relevant, then there's not really a need to include them, to be more parsimonious. But I think with something like this, it almost reminds me of if you're building, like if anyone's ever done like missing data stuff, if you're building like a multiple imputation model, the kind of whole thing there is throw everything that you can in that could possibly inform it in order to create the most kind of robust result that you can. And it's not exactly the same, but that's sort of what it reminds me of when you're creating an index like this. The idea is like, if you have the sample size, put in anything that you think might be relevant in the beginning, and then you can kind of fine tune it from there, which Anaïs, you talked about earlier, which that was the approach that you took with your colleagues in deciding on what variables were going to be included.
We didn't include variables that were not identified in the literature or not identified in our expert committee. So they were all deemed to be relevant at the beginning. And in the many validation studies, after take the tool and reapply it in their context. In our case, it's not a very reapplicable index, but it's more, this is an example of methodology. People can try to apply it in their context with their sample size, their field, the variable important in their context, and after use a different approach, use PCA, do not use it. It's just like adaptable, I think, methodology when you want to create a composite score based on the variable you have. So maybe someone will have a 3,000 sample size, per participant sample size, and we want to include maybe just 10 variables. So maybe it's okay. So the different contexts, people have to sit down and choose which path to take.
Mm-hmm. And I think the perspective here is really good too, because you mentioned that you weren't a gender researcher, and I am not one either. And I've been to a few talks on, sex and gender and research, and I think a lot of times, at least my experience has been that the talk is around we need to be including measures of gender in research as opposed to just measuring sex, and we need to be doing this. But for someone like myself who does secondary data analysis primarily, who doesn't really have a say over the data set or the questions that are asked, it's a little bit, I feel a little bit lost because I'm like, I understand the value, but it's just not my, it's not my choice. So I really like conversations like this where you're saying, okay, if we do have an existing data set and you have sex and you have these gender related variables, here's actually how you can somewhat measure gender if you're not doing it right from the start, which is, I think, really helpful for people like graduate students who might not be running their own study.
And nowadays, in every grant, scholarship application, you have to explain how sex and gender is considered. So even if you don't measure gender with the perfect tool, it's important to measure it. So people have to try to find ways that are not necessarily perfect, but try to find ways.
Just one last question from the audience. So how much discrepancy did you find between the biological sex and the true gender within the members of the cohort?
I don't know if Amanda, you can put the graph.
Yeah, sure.
Histogram is a nice presentation of the distribution of the index.
Sure, and I think you were thinking, this one?
Yes. So you have at the on the screen the proportion of participants who had different scores, because the gender score had the value between 0 and 100. So you have the distribution, for example, in men, in gray, dark gray. So there was many men that has masculine score, the beginning, the peak. And after, you can see that some men had feminine scores. So the mountain is like white.
Over here.
And the same thing for women. There was almost a normal curve for women. So most of women had like 50 to 70 values on the score. So more feminine than masculine, but there was very masculine ones and very feminine ones. This graph is simple, but we thought it had great value because even if the score was computed based on sex, it measures something else. So it's related, sex and gender, but it measures something else. So this graph was a quite an important argument towards the value of an index like this, even if we calculate it based on sex.
Perfect. I just want to be mindful of the time here. We have about 2 minutes left. And so I just want to quickly ask as well, why did you decide to publish in the Canadian Journal of Public Health?
In our literature review about CCHS, we found many articles about researchers that use this database, and many of the references were published in the Canadian Journal of Public Health. I think it's a database that has value for Canadian researchers. It's a database, as Amanda said, that is known in the country. So we thought it was like the good place to publish it.
No, perfect.
And normally normally I try to publish in pain journals, but this methodological paper was not about pain. So we looked at other possibilities.
No, it's such a good fit, especially with the background in public health. So I think it's a really good decision. And just because I'm interested in time, I just want to plug our next Journal Club session, which will occur on November 25th from 1 to 2 p.m. And Kabisha, incoming medical student from University of Toronto, will be presenting a paper called Psychosocial Adaptation to Climate Change in High River, Alberta. This is policy and practice. And CPHA members can register through the members portal, and non-members can register through the Canadian Public Health Journal Club link as well. And for those of you who are not, I encourage you to become a member of CPHA. It's a great way to connect with other grad students, early career professionals, and other student trainees. And if you are interested in learning more about CPHA, please feel free to reach out with me. I'm happy to have a one-on-one conversation about all we have to offer. And I thank you so much for attending our second journal club session and hope to see you at the next one. And thank you so much to our lovely presenters and author for a fantastic presentation and a wonderful discussion.
And if I can allow myself, Ian Calvert published in the Q&A section that the Canadian Journal of Public Health has a specificity about including sex and gender in article published in it. So it's important to consider, and it's a journal that puts forward the importance of sex and gender. So it's important to do so nowadays.
Mm-hmm. Mm-hmm. Perfect. I will share that link in the chat, actually. And also, if you guys don't mind or have 2 minutes, I'm filling out a feedback questionnaire for the session. Thank you. Sorry for keeping you over time. Thanks, everyone. Bye.
Thank you, everyone. Have a great day.
Thank you
very much.
Bye-bye.